Well, a lot of great work you and your team are doing. For a rural healthcare system like yours, how does HASP allow you to continue giving great care to patients every day?
Yeah, great question, Anthony. So, particularly from a rural perspective, there are simply just less resources, less population, less educated population, less income in the communities. And so the HAS funds allow us to do things that maybe in larger, richer, more urban areas, there are other ways to provide. So, for example, one of the programs that we've done with great success has been the funding of our community health workers. So, community health workers are not clinicians. They are not doctors or nurses or clinical social workers. They are folks that don't have a clinical background, but their job is to really fill in the gaps between our patients and the needs that our patients have because of these social drivers of health. That's a term that, we use a lot these days, but really, social drivers or determinants of health have been around for years and years. It's the fact that folks don't have transportation. It's the fact that they don't have somebody to take care of their children if they need to go get health care. It's the fact that maybe they have a hard time understanding because sometimes information about health is written in a very high level. I look back at the experience of my own family who all came up in a rural environment. My great-grandfather couldn't read or write. My grandparents, worked in a textile mill their whole lives. And so the things that they struggled with back then are the same things that our patients struggle with now to be able to access care, even if it is out there. And so these community health workers are the folks that come alongside them and help navigate them to the resources that are available, within our system, in the larger system, with other stakeholders, with local charities. And that's one of the things that HASP has given us, again, with some grant funding dollars, the ability to do that. It's not something that otherwise gets paid for, but it's something that's crucial to improving quality outcomes, keeping folks from going to the emergency department over and over for preventable conditions, making sure that if they have surgery and they get discharged, that they don't get an infection simply because of their living conditions. Making sure that children that are seen in the local pediatrician's practice have access to counseling when they need it. So these are all things in a rural area that the need is greater proportionally, but the resources are also proportionally much less. That's an example. And again, HASP is what is making up the loss that we would normally experience for every additional Medicaid patient we care for. And so if you think about other businesses or services that are provided out there, there's very few where you want to care for more and more folks where you end up going in the hole for the cost of care on each one.
It is. It's a balance, right? It's got to be hard in a rural area. I mean, just in general, economies of scale, and like we talked about with the MRI machine or anything else, fixed costs, and how do you cover that fixed cost? Obviously, the more population you have, it's easier to cover that. I mean, it's like that in every sector, though, in rural North Carolina, right? I mean, you think about internet access or broadband. I think that's part of it too. To your point, though, in a lot of other areas, they can kind of set their own prices to a certain degree. And really in Medicaid and Medicare, you're not setting your prices. Those are set by the federal government. So you are taking that. It is a push and pull. HASP is obviously linked closely to Medicaid expansion in the House Bill 76, which was the bill that passed that enabled the statute for HASP. Expansion was also in that legislation. As mentioned before, hospitals are paying the non-federal share for that. There's obviously a bunch of things being discussed at the federal level with the new administration as they look to cut costs and provide, tax cuts. They're trying to look at how they can get the funding they need at the federal level and reduce the deficit. Part of the conversations right now are discussions around changing the FMAP, which is the matching percent that the feds pay for Medicaid expansion compared to the state. For expansion, it's 90-10. So the federal government pays for 90% of the expansion population, whereas hospitals are paying the other 10%. There's discussions about changing that 90-10 split, which would effectively eliminate Medicaid expansion in North Carolina, which, is 600,000 plus individuals losing healthcare coverage, which is obviously a big deal. Most of those individuals in rural areas, which would be, catastrophic for North Carolina specifically. But then there's also talks about cutting payment programs for Medicaid, such as HASP. So, David, with that, if these cuts, were to occur around expansion or HASP, how do you see this impacting your patients and the care that you provide at Scotland Health to your community?
Yeah, so let me preface with this. I know that for folks that may be listening to this podcast, it will be tempting to say, well, gosh, these hospital folks are always talking about doom and gloom and how bad it is and the sky's going to fall. But realistically, we need to think about these policy decisions and these changes that are being discussed in the larger context of, do you want healthy rural areas and small towns in North Carolina? And here's the way it would affect us directly as a hospital. And then I'll talk more broadly about the overall population spread and growth in North Carolina. So first, if the funding split changes and that triggers a reversal of Medicaid expansion. So we don't get paid with the folks that are covered by Medicaid, the cost of providing service. But the folks that are covered now that weren't covered before, then they go back into the self-pay category. And so those folks, on average, pay 1 cent on 100 cents of what the charge would be. They would be charged for services. So in essence, there's a lot of folks that then would not be covered by healthcare insurance through Medicaid, and they would, again, not have any sort of funding source. So that is additionally more folks that we're going to care for with absolutely no offset to the cost of providing that care. We are committed to our communities, and we're going to do our very best to find a way to provide that care, but it is making it more and more hard to try to do that. So that's the first thing. And then if the HASP payments go away, so if let's say that we lose Medicaid expansion and we lose the HASP payments, now you've compounded the problem of getting rid of the Medicaid expansion. And so these programs that we're providing that otherwise do not get paid for are things that we, to be able to just stay financially afloat, we wouldn't be able to provide many of these programs. It's through leveraging these federal programs that we're actually able to provide the services that, quite honestly, health insurance should be paying for from the very beginning. The things that help prevent readmissions, the things that help prevent sequential infections, the things that help to lower blood pressure in a doctor's office, rather than somebody having a stroke and having the disaster that comes from that in terms of the impact on their body. But again, zooming back out again, if hospitals close because of this, if healthcare services within rural communities and small towns diminish because of these larger policy changes, then what it does is it ends up, in essence, forcing populations into urban areas and suburban areas. And there's some places, like where I grew up in Union County, that started out very rural and now is very much just a suburb of Charlotte. Those places are going to do okay. And Wake County will do okay. And New Hanover County will do okay, even if in those urban areas, there will be folks that are still not receiving the care they need. But the places that are really going to get hit the hardest are rural areas and small towns. Anthony, it's a shame, but the best predictor for somebody's health status, that is how healthy they are, is not their ethnicity, it's not their income, it's not their level of education, things that you might think would interact with social drivers of health. It's their zip code. And the big difference is whether it's a rural zip code or whether it's a suburban or urban zip code. And so for the folks that are part of this team and my colleagues that are in rural areas and small towns in North Carolina that think that what we have here is special, that's what we're fighting for. I'm not trying to overstate it, but the things that I think make North Carolina so special, those are the things that come out of these areas, not larger spaces where culture has been homogenized. Think about, and I know this is really way off target, but think about the great jazz music back in the 40s and 50s that originated with people that grew up in rural areas of North Carolina and South Carolina. You're talking about John Coltrane. You're talking about Dizzy Gillespie. You're talking about Nina Simone, all of whom came from small towns and rural areas of the state, and the impact that they made on American jazz music. As people move to big areas where the culture is homogenized, you lose those people in the future. These decisions, even though specifically are tied to hospitals, it's part of a larger decision we need to make about, are rural areas and small towns important? And I believe they absolutely are.
I totally agree, David. We start talking about specific programs being cut. I feel like we kind of, talk about them in a vacuum instead of looking at the global picture and realizing, there's also input cost that go into running a hospital, whether it be, machinery or staff. And so what is that balance? Obviously, no one wants a high healthcare bill. There's really no other business where you have almost this cost shift or a subsidization because some people wouldn't be paying for healthcare, right? That doesn't really happen when, you go and you pay for a car or, your food at the grocery store. Just makes me think, what can we do here to defend these programs, right? Our lawmakers really not looking at healthcare cuts in a vacuum, but the totality of the system and what we have.
Yeah, I'll be honest. I think, and I'm as much to blame as anybody, but we need to be better about telling our story. Most of us, particularly in rural hospital settings, we're busy day to day trying to make sure that the things are running well, but we really need to take the time to share some of these good things that we've done with the HASP funding, some of the things that otherwise wouldn't be covered, wouldn't be available, wouldn't be paid for. And we need to reach out both to our elected officials and to the larger constituency, the folks that actually vote to elect those officials. If they don't understand that this isn't just a nameless, faceless program with, this 4-letter acronym, that it really does mean their local hospital, their local physicians, services that help them when they need it, the things that help their children or their grandchildren, right, when they're being born. We need to get better at that. And so I think that's the way to do it, is to take it to a local level, and even just some of these stories like I was sharing with you about the community health workers and what they're able to do. But again, those are services that insurance typically doesn't pay for. So if we didn't have HASP funding to be able to help provide this funding source, then there's a lot of the really good things that we've seen in terms of improving quality and outcomes that we just wouldn't be able to cover, because otherwise we'd be losing money on these services. And to stay long-term financially successful, we'd have to cut back and actually shrink what we're doing.
I agree. I do think education to our policymakers and lawmakers is a big deal. With Josh starting at the association, I know that's been one of his big, talking points, is really making sure that we're working collaboratively with our lawmakers to look at a solution. I do really appreciate you coming on, David, and telling that story. I hope that I can work with other CEOs across the state to tell the story about these funds and how they are making a difference to local communities and the patients of North Carolina, especially in rural areas. So thank you for being here today.
Thanks so much for having me. It's been an honor just to be able to talk with you about this work that we're doing. And this problem is too big for any one of us, but all of us need to and can be part of the solution. And that's what we're committed to doing.